So welcome to this webinar. My name's Alison Hammond. I'm a Professor of Rheumatology Rehabilitation at the University of Salford, and my remit is to give an introduction to patient-reported outcome measures. So I'll be discussing what are patient-reported outcome measures, or PROMs or PROs, and why use them. How can you identify which PROMs to use? What are key questions to ask when you're choosing a PROM? And then briefly how a PROM's developed, and yes, it does take longer than you think. So first of all, what are PROMs? Why use them in your practice audit or research? Well, outcome measures are either broadly health professional or patient-reported measures, and you're familiar with health professional ones. These can be non-standardised, observation, physical examination, and homegrown checklists. And a few years ago, we surveyed rheumatology OTs and found out that most assess patients' daily activities with a homegrown checklist, and most at the time. So standardised measures use standardised procedures. For objective tests such as grip strength, you follow published procedures. Subjective tests like manual muscle tests, you're using your clinical judgment but also following standard procedures. There are structured observational tests like the assessment of motor and process skills, which assesses procedures for doing daily activities. And there are standardised semi-structured interviews like the Canadian Occupational Performance Measure. So patient-reported outcome measures are usually paper-based, and they're increasingly available digitally. They can be completed before appointments, at home or in the waiting room, giving staff ready access to patients' perceptions. So common examples are pain, visual analogue scales, mood, activity ability. Probably you're used to the health assessment questionnaire, and we've also constructed the evaluation of daily activity questionnaire, which is a detailed measure of daily activities. And there are measures of social, work, health status, quality of life. So patient-reported measures are a measurement of any aspect of a patient's health status that comes directly from the patient without interpretation of the patient's responses by a physician or by anyone else. And in this model you can see Wilson and Cleary classified measures of health outcomes. As one moves from the left along to the right, you can see the levels range from cellular through to the impact of the health or disease on the individual, to their quality of life and their social environment. And professional reported outcomes work well for components to the left, and patient-reported outcomes are increasingly helpful to the right. So using patient-reported outcomes, or PROMs, has got benefits in practice. They add the patient's perception to their consultation. They help us understand the impact of patients' condition and problems in real life. They're systematic and they can guide interventions. Because completed before appointments, they save time assessing and interviewing. So why don't we use them more often? Why do we still use homegrown checklists, for example? Well, often therapists say it's because there's lack of time, they don't know what to use, the PROMs take time to score, you still need to read and interpret the scores, so it can just be easier to ask people. So here's an example of PROMs in practice, and it's the Swedish Rheumatology Quality Register, running for over 20 years. Patients log in and they complete disease, function and health measures online between their visits. Clinic staff use the information to guide frequency of appointments. They track treatment responses over time. There's a user-friendly dashboard for staff and patients. And both can use the data to guide their treatment, for shared decision-making and to support self-management. So the dashboard helps people engage and it also increases their confidence to manage their condition. Clinical outcomes have been shown to improve after patients start measuring, reporting and sharing responsibility for managing their condition with their team. And Karen, someone with RA, said, "Nowadays I work together with my doctor and the computer for every change in my treatment. I can check my disease at home between visits. Before I go to see my doctor, I report on and measure my own health. It's easy. I just click on the screen and enter how I feel." So online platforms for PROMs are being developed in the UK as well, which makes it easier for staff and patients to use them. In our research group, we focus on developing measures of daily activities, work, hand function, leisure, to help people identify their own everyday problems, work together with therapists to find solutions, and take action to self-manage. And these are being digitised on the mskhub.com. So how can you identify which proms to use? Well, first of all, ask, what do you need to know about? What are your aims? For example, your department runs a patient education programme and you want to know if it works. Well, review the programme's aims. Is it to improve the patient's understanding of their condition and management? So try using Hill's Patient Knowledge Questionnaire. Is it to improve their confidence in self-managing their condition? Try using one of the arthritis self-efficacy scales. Is it to improve adherence? Perhaps you're teaching physical activity and exercise. You could try the International Physical Activity Questionnaire. Is it to improve their activity ability through teaching joint protection and hand exercise? You could try using our Evaluation of Daily Activity Questionnaire. Is it to improve their health status? You could use the Arthritis Impact Measurement Scale. So here I've given you a list of where can you find proms, and here are some good resources. So for rheumatology measures, the first one was a special supplement of arthritis care and research, free to download, with reviews of measures and links to where to get them. The European League Against Rheumatism's Outcome Measures Library has a searchable database, and the OMERACT Outcome Measures in Rheumatology does as well. If you're looking for perhaps slightly more generic measures, McDowell's Measuring Health book's a good resource, the Rehabilitation Measures database, and the COSBIN database are systematic reviews of outcome measures. So what are the key questions to ask myself when I'm selecting which prom to use? So you've searched the databases, you've identified perhaps several measures of daily activity or self-efficacy or physical activity, whatever it is. Which one are you going to use? It's not just does it look nice, is it quick for the patient to do and can I score it easily, although they are sensible questions. You need to ask yourself, is it fit for purpose? So does it have appropriate psychometric properties, which means reliability and validity? Is it meaningful to your patients, and is it practical? So let's start with asking about psychometric properties. Let's say that you want to measure confidence and ability to self-manage or self-efficacy because it's a key aim for patient education programme. You've identified 2 self-efficacy proms, but which one to use? Look at the reviews and the databases to find summaries of the properties, and then you can compare and contrast. And COSMIN, or the consensus-based standards for the selection of health measurement instruments, summarises the 4 key psychometric properties to look for when selecting measures are reliability, validity, responsiveness and interpretability. So we'll take a little tour of these next. So first of all, reliability. There are 2 main types for proms. The first is internal consistency. So do the items or questions within the prom measure the same construct or concept? Does the review or the results that you found include a test called Cronbach's alpha? If a prom has an alpha score greater than 0.7 on a scale of 0 to 1, it can be used in audit and research with groups of people. And if you want to measure an individual's progress, then the Cronbach's alpha should be more than 0.85. Secondly, we need to think about test-retest reliability. If a person completes the prom on 2 separate occasions, giving nothing changed, or they felt about the same in between, are there similar results? Look for published intra-class correlation coefficients. If the ICC is greater than 0.75, it's got excellent reliability. So next we look for evidence of validity. So again, there are several types. The first is content validity, and we can partly get away from statistics a bit here. Again, in the databases and the articles, look for information about how the prom was developed. We should use proms generated by patients, not just health professions coming up with content. Check, were patient interviews conducted and analysed to generate the content? Did patients help decide what to include? Is that there evidence that all the most important concepts to patients are actually being included? And then what types of validity were tested? In criterion validity, a PROM is compared to an existing gold standard, and there are two types here, concurrent and predictive. For example, the RA Work Instability Scale has 23 true-false questions measuring work problems. It takes about 5 minutes. The developers Gilworth et al. Found that scores correlated well with the results of full ergonomic assessments conducted by a physiotherapist. So the RA Whiz has got good concurrent validity, and it also has good predictive validity. Tang et al. Found that people with RA scoring more than 11 were significantly more likely to have reduced their work hours a year later. So the RA Whiz scores can help identify who needs work rehabilitation. So we can also look for construct validity, and again there are two types here, convergent and discriminative validity. Scores on a PROM should correlate with other similar measures. For example, when we developed the Evaluation of Daily Activity Questionnaire, a detailed measure of activity ability, we asked people to complete the EDAC and also the shorter Health Assessment Questionnaire. EDAC and HAC scores correlated well, demonstrating convergent validity. And we also examined EDAC scores at people who said they were either in good, poor or moderate health, and EDAC scores were significantly different between these three groups, showing discriminant validity. So next we look for evidence of responsiveness. Can a PROM detect true change over time? It examines whether scores actually change in people you expect to either improve or to deteriorate. So, for example, Sarah Hewlett and team developed the RA self-efficacy scale, evaluating confidence using a range of self-management behaviours. And they expected that people attending patient education programmes should improve their self-efficacy scores from before to after. So they asked patients attending patient education programmes at 11 different rheumatology departments to complete the scale before and 8 weeks later, and there were significant improvements in their RA self-efficacy scores, indicating the PROM's responsive and detects change. So fourthly, how can we interpret the PROM scores? What do the numbers or the changes in the numbers mean? Look for information again in PROM articles, databases, reviews. For example, what does a score of 1.2 mean on the HAC? From reviews we can find that a score range of 1.1 to 2 is moderate disability, so 1.2 is the low end of moderate. If a patient's pain score drops from 7 to 5 from before to after therapy, is that an important difference? Well, Wolf et al. Has demonstrated the minimal important difference on a 10-point numeric pain scale in RA is 1.1, so a change from 7 to 5 is likely meaningful. So there's a lot to be considered when you're choosing a PROM. Start by using databases and reviews. Other people have already done a lot of the hard work putting the information together, comparing reliability and validity. But statistics are only part of the story. You also need to ask, is the PROM meaningful to patients? Does it measure what's meaningful to your specific patient group? If you've got 2 or more valid, reliable, responsive measures evaluating the concept you want to measure, look at the content. Which is more meaningful to your patients? Ask them. And last but not least, is it practical? Is it available? How long does it take? Do people understand the wording? Is there a reliable, valid version available in British English? Have you got the correct and latest version? Is there a published manual or instructions about how to use the PROM and how to interpret it? Is it copyrighted? Do you need approval? Is there a fee? So let's recap. The key questions to ask yourself are, is it fit for purpose? Does it have good enough psychometric properties? Is it meaningful to your patient or client group? And is it practical to use? So sometimes I meet therapists who say, I don't like any of the measures of whatever it is I found, that I could just make one up myself or I could change some of the content. But if you do that, it won't be of a valid, reliable measure, and the scores can't be interpreted. So you might as well continue using non-standardised checklists. So I'm going to spend the last few minutes just summarising how PROMs are developed, and so you know what you're letting yourself in for if you choose to do so or to modify a PROM. There are 4 key steps. The first is developing items to include in your PROM. So this starts with a literature search and review to help you define what the construct is or concept that you want to measure. And then you need patient input. Interview about the concept, what's meaningful to them, analyse that data to identify themes or items. You might have some health professional input, you might look at other published measures, or you might find a measure in another language or American English, which you need to translate and linguistically validate. So I've mentioned the evaluation of daily activity questionnaire already, and originally it was a 100-item measure developed 20 years ago in Sweden, and it's still used by OTs there. Patients fill in the EDAC at home and take it along to OT so the therapist can quickly see what their patients are and get on with finding solutions. And I'll briefly summarise what we did to develop an English version. And if you want to know more, we can discuss it in questions and answers. So we translated the EDAC from Swedish to English. We considered the best wording. We agreed that. We translated it back to Swedish to check it was still the same meaning. Patients filled in activity diaries. We asked about common problems to update content, ran focus groups to decide content and wording, held expert panel meetings, agreed content, tested it with patients and finalised it. And then we psychometrically tested it all together in some 1,200 people with 8 different types of musculoskeletal condition, including RA, OA, lupus, AS. And we analysed data to determine reliability and validity and developed a manual. It takes about 20 minutes, which sounds a long time, but the patients all thought it was the right length and it would be a good way for OTs to find their problems. So now we're making the EDAC more easily available to patients and health professionals. And my colleague, Dr. Yulise Pryor at Salford, is developing the MSK Hub, a website to support patient self-management, as well as information for health professionals. Users can click on self-assessments, daily activities. Each of the 14 domains or subscales has its own section. So here they click on cooking. They can identify how difficult or not it is to do peeling and chopping vegetables, carry pans, bake, and the printout summarises results and can be shared with a health professional. We've run a whole series of EDAC projects, testing paper versions in RA, other conditions, Dutch and German versions, and now a digital EDAC. So if you do decide to develop your own PROM, or you want to translate or change an existing one, it is a lot of work. Or get in touch. Would you like to do a research degree, or would you like to collaborate? So to summarise, what we've discussed is what are patient-reported outcome measures, how do I find them, what do I look for, how PROMs are developed, and why it does actually take longer than you think to make one up. And finally, I've got some references for you here on the slides. And if you'd like to get in touch with me, this is my email, ahammond@salford.ac.uk, and we've now got some time for questions and answers. Thank you very much. Okay, so I think we're ready to take some questions, and the first one's come in. Can you tell us some more about how you did develop the EDAC? It seems to have been quite a complex process. Is that what's usually done? It is actually a complex process to develop PROMs. So we were translating from a Swedish to an English instrument. And what we were first doing was linguistic validation. So we were translating from Swedish into English. And you need 2 independent translators in order to do that, who forward translate. A panel then agrees the translation, and then it can be backward translated into Swedish, and your Swedish or whatever other language colleagues then look at the translation and decide whether it still means essentially the same thing. So having done that, you can then go on and look at content validity, in which you're doing work to develop more items. We needed to update the EDAC because it was considerably out of date at 20 years old. There were no items about computers, for example, and it was interesting that we found there were items missing that were in fact very common problems in the UK. So there are no problems like turning taps or lifting kettles, and that was to do with the cultural difference between Sweden and between Britain. The Swedes are a nation of coffee drinkers, and it's only relatively recently they've actually had kettles in their kitchen. So there was a lot of work to actually generate items to make it culturally valid for the UK. So we've got another question. You explained you compared the EDAC against the Health Assessment Questionnaire. So why did you need to develop the EDAC for the UK when the HAC already exists? Actually, that's quite a reasonable question. The HAC's got 20 items and the EDAC includes 138 items, which is an awful lot of items, you might be thinking. But one of the reasons, when we were doing a survey of rheumatology occupational therapists to ask, what do you use? Why do you use checklists? Why don't you use something like the Health Assessment Questionnaire? The general reason was because it wasn't sensitive enough to pick up the range of problems that patients might have. So it wasn't actually very helpful for treatment purposes. And in terms of an outcome, its problem is the scoring, because if people use an assistive device, then an item is scored worse on the HAC. Whereas, of course, for occupational therapy, part of our intervention might well be providing an assistive device in order to help people improve. So there's a counterintuitive effect in the scoring in that people are worse after occupational therapy if it includes provision of assistive devices. So there's another question come in. You explained there were several types of validity on the Cosmin slide. That's the one that had all the circles on it. And it showed that content validity included face validity. So what's that? And can you say a little bit more about how content validity is established? So face validity is the sort of most straightforward form of content validity. What happens is you literally look at the measure and decide on the face of it, does it measure actually what it's meant to measure? So if you're interested in a self-efficacy scale, you might be interested in, for example, whether people can manage their symptoms or whether they've got confidence in being able to perform health behaviours. So you and your research team or your colleagues would look at the different available self-efficacy scales and decide what you most want to measure. And then you might, for instance, say, well, are people confident about using health behaviours? And when you look at the variety of measures, you'd see that the RA self-efficacy measure actually addresses that most obviously. So in terms of other forms of content validity, some of the things you might be doing are to, I mentioned that you should be looking that developers have actually interviewed patients in order to generate items. So after that, your expert panel might be looking at the items to decide their relevance. You might well be interviewing, or you would be interviewing patients, and part of that interview is actually asking them their opinion about the content, how relevant and appropriate that the items are, so that you can weed out anything that from their perspective isn't appropriate to include. And you might do other forms of content validity. So for example, in our EDAC study, we were looking at daily activities, so we compared with what's called the International Classification of Functioning Core Set for RA and for the other musculoskeletal conditions we tested the EDAC in. And we looked to compare that we included relevant items in the EDAC that were also in this World Health Organization ICF classification. So we've got another question. I think I might have missed one if you want to go back. The Cosmin slide also showed about construct validity. So it included several types of hypothesis testing, structural validity and cross-cultural validity. So yes, I did explain about hypothesis testing. That was convergent and discriminative validity. but it didn't actually mention structural and cross-cultural validity, partly because I thought you might be getting a bit tired of a long list of different sorts of validity and reliability. So structural validity, when you've actually gathered all your data in, one of the things you would do is to use strategies, statistical strategies, like factor analysis. So if it was a newly developed PROM, what might be happening is that researchers are using exploratory factor analysis, in which they're looking which domains or subscales the items fall into, and if there are any items that don't fit that structure. If, like us, you are translating from an existing measure, the Swedish EDAC, into English, it already had a structure developed in Sweden, and so we used what's called confirmatory factor analysis to identify that the domains that were developed in Sweden kind of work in the English version as well, which they did. So, we've leapt on to another question. Can you tell us a bit more about the mskhub.com? So I mentioned and showed you some of the screenshots of this, which is an online platform that my colleague in the Clinical Rehabilitation Research Group at Salford is developing, and that's Dr. Elise Pryor. So she's taking forward the digitisation of the variety of patient-reported outcome measures that we've developed, and you saw an example of the EDAC, but there's also others on hand function. We're busy at the moment doing a project working on developing English versions of a range of work outcome measures originally developed in Canada, and they'll be going onto the site. One of the things that we're hoping to do with, for example, the EDAC is not only that patients could use it and take printouts off to see therapists, but we do want in time to be able to link those problems to solutions so people could assess themselves, and when they find they've got a problem, they can link on suggestions for what might be different ways of performing the activity, so it's a self-management support. And we'll also be looking increasingly to develop health professional content, perhaps linked to PROMs, but also to some of the self-management education research that we've been conducting over the years. I'm a final year physiotherapy student. How do I get involved in developing patient-reported outcomes for underexplored qualitative areas that interest me? Now that shows a lot of commitment from somebody, I have to say. Well done. I think you might have gathered it is quite a lot of work. So I'd suggest that if you are genuinely interested in taking forward doing research in this area, that one of the things that you should really think about is going on next to do your MSc, and you can always get in contact with us if you need future support. So the next one is, thank you for this fantastic presentation, thank you very much. What would you advise clinicians who want a short practical tool without the need for performing statistics? I suppose it's a question of what the short practical tool is for. Actually, a lot of PROMs, surprisingly, if you're actually looking to use a PROM, it depends what you're using it for. If you're wanting to use it in practice, you do need to make sure it meets the criteria of reliability and validity and so on, as I've said. But many PROMs actually require just simple adding up. Our EDAC, although it seems quite long, each domain, you just add up the scores and write the score down, and you can plug in the scores into a little diagram to display them. And so that will come up with your answers quite quickly. How would you estimate a clinically meaningful change from a PROM? Now that's actually quite a thorny question, and I think we might even run out of time to answer it. But what I'd suggest is that if you are interested in looking at a lot more detail in outcome measures, I'm going to suggest, because time's running out unfortunately, that you might like to use this book, which is also on the reference list that's on the webinar, and you can download that afterwards. But this is particularly helpful at looking at how you might estimate things like clinical meaningful change or any of the other aspects of psychometric properties. So I found that a really helpful handbook to help me with the process of developing PROMs. So that's the end of the webinar for this evening. I'd like to thank you very much for joining us here for this evening. So thank you very much for your attention. Bye now.